Good evening, all. Welcome the annual Alejandro Guansing Memorial Lecture of the Philippine Medical Association. Thank you for joining us this for our talk on COVID. So today we will have 3 short talks followed by a Q&A. Please use the Q&A function to ask questions. It's at the bottom of your screen. This webinar is being recorded and there will be links afterwards in our Instagram page at PMA_Wisconsin and our Facebook page at Philippine Medical Association of Wisconsin. A PMA-W general meeting will follow after the webinar, and we will send you a separate link in the chat box. Our partner, the Philippine Center Free Medical Clinic, a nonprofit staffed by local volunteers, provides free medical care to uninsured and underinsured individuals in southern Wisconsin and northern Illinois. Donations and volunteers are always welcome. Please email PMA-Wisconsin2021@gmail.com for more information. You can also send tax-deductible donations via Venmo to Meredith Cruz at PMAW-fundraising. The QR code is here. I would like to introduce our speakers tonight. Dr. Abiad is a graduate of the University of Philippines College of Medicine. He did his internal medicine residency at the Medical Center of Central Massachusetts and his infectious disease fellowship and master's in public health at the University of Illinois at Chicago. He is currently an infectious disease specialist at the John Stroger Hospital of Cook County and assistant professor of medicine at the Rush Medical College, both in Chicago. Dr. Franco Felizarta, also a graduate of the UP College of Medicine. He did his internal medicine residency and infectious disease fellowship at the State University of New York Health Science Center at Brooklyn. He is solo private practice in Bakersfield, California, and is an HIV specialist at the Kern County Department of Public Health and State Santa Barbara Public Health Department. Linus Santo Tomas is known to all of you. He also went to med school at the University of the Philippines College of Medicine. His internal medicine residency was at the Cleveland Clinic, and he did a pulmonary critical care fellowship and master's in epidemiology at the Medical College of Wisconsin, where currently associate professor of medicine. So we will start with Dr. Abiad will talk about COVID, current of COVID. Dr. Felizarta will talk about vaccines and the impact, and Dr. Santo Tomas will talk about chronic COVID conditions. Thank you, and we will start.
Good evening, everyone. For the next 15 minutes, I'm tasked to just give a brief overview of the current management of COVID-19. We'll start with the outpatient therapy. So when can a patient with COVID-19 be managed at home? A vast majority, above at least 80% of cases have mild disease that can be managed without hospitalization. Again, these patients should have mild symptoms, particularly no shortness of breath, and they should be able to be adequately isolated so that they don't spread the infection, and also monitored for worsening. So primarily, these should be patients at low risk for severe illness. And what are the risk factors for severe disease? They are older age, obesity, pregnancy, chronic kidney disease, diabetes is a very big one too, immunosuppression, then cardiovascular disease or hypertension, and chronic lung disease. Doesn't mean that if they have any of these, they can't be monitored at home. We should just have a lower threshold for hospitalizing. How do we manage these patients at home with COVID-19? It's really primarily supportive care, analgesics, antipyretics, symptomatic therapy. And then mainly the most important is the close monitoring and contact with the healthcare provider, whether that's by telemedicine visits or just phone calls. Mainly we tell them to watch out, most importantly, for any shortness of breath, especially if they have shortness of breath at rest or when speaking. and pulse oximetry, and I'll go over that briefly in the next slide, is very useful for this. And again, very important to make sure they're isolating well to prevent spread of infection to other household members and pets. Household pulse oximeters are now readily available. They're about 20 to 30 bucks on Amazon and are very useful for assessing clinical status. So this is something that's really become very common during the pandemic. Just a reminder, they're supposed to be used on warm fingers without nail polish. And you want to watch out for when the SATs drop less than 95% repeatedly. Are there any outpatient treatment options for COVID-19? Are there any medications that we can give for COVID-19 in the outpatient setting? And for that, I'll go to the NIH COVID treatment guidelines and the therapeutic management of non-hospitalized adults with COVID-19, which really list just one treatment, which is monoclonal antibodies, which are developed against the spike protein of the SARS-CoV-2 virus. This is the only currently recommended treatment for the outpatient treatment of COVID-19. And the available agents under EUA, emergency use authorization of the FDA, and that we should receive special training for pronouncing these, but there's bamlanivimab plus etesevimab. There's the cocktail of casirivimab plus imdevimab. This is the Regeneron cocktail, and there's also sotrovimab. So these are all given sort of a single IV infusion. How effective are they? Basically, and these show that most of them, they really reduce hospitalization and death, say from 7% in the placebo arm to 2.1%. So they reduce hospitalization and death by 70 to 85% in high-risk patients. So they really are a somewhat underutilized treatment for outpatient treatment of COVID-19 in high-risk patients. Who exactly are monoclonal antibodies recommended for? So they're recommended for the early treatment of symptomatic COVID-19 in patients who are not hospitalized, again, outpatient treatment, and they should not be requiring oxygen with high risk for severe illness. Again, high risk being the elderly, obese, although for the EUA, they actually have BMI of greater than 25, which is really the majority of the American population. Chronic kidney disease, diabetes, and the rest as listed there. It's important that these be given as soon as possible after diagnosis. So the EUA lists up to 10 days after symptom onset, but really the effects are best if they're given within like 5 to 7 days of the onset of symptoms. All are given single dose. They're all given IV, although the casirivimab, imdevimab can be given subcutaneously. So again, these are sorts of, there's logistically a little complicated. The patient has to come in to an infusion center to get this treatment generally. And anyone who gets the monoclonal antibodies should avoid getting the COVID vaccine for at least 90 days after treatment, because the circulating monoclonal antibody will neutralize the effect of any COVID vaccine that you give afterwards. Any downsides? Well, there are rare infusion-related reaction events, but they're usually not severe. Fever, chills, urticaria, flushing. The other downside is the cost. They cost more than $2,000 per dose. Now, the federal government basically bought all the doses in the US. So basically, they're all paid for by the federal government. There is no fee for the medication itself, although infusion facility fees may apply, although these are covered by Medicare, Medicaid, and commercial insurance. Where can one get these monoclonal antibodies then? So again, for patients who meet the criteria that we talked about, the monoclonal antibodies, again, are distributed by the federal government through the HHS, the Department of Health and Human Services. So they have a website where you can just look up. For instance, here I just searched for Milwaukee. Within 20 miles, there are 14 different facilities where anyone can go in and get the monoclonal antibody treatment if they meet the criteria. Now, do we have any oral medications for the outpatient treatment of COVID-19? Again, the NIH recommendations do not list any, but are there any that we have or are in the pipeline? So fluvoxamine is an antidepressant that's been around for many, many years. And there's been, it looks like it is promising, but the data so far, there's at least one randomized trial where they looked and it showed that they decreased hospitalization in mild cases by 31% with a treatment course of 10 days. Again, this medication is available in the US, has been for many years, and it's really fairly cheap, just $4. However, at least this study, there are some methodological weaknesses. It was done mainly in several centers in Brazil. So for most feel that it's promising, but not ready for prime time yet. So for instance, the NIH guidelines say that there's not enough data to recommend for or against. And that at my center, for instance, we are not using fluvoxamine yet for the treatment for COVID-19. Hopefully, we'll get more data soon. There's been a lot more press about two agents that have two novel agents, molnupiravir from Merck and Paxlovid from Pfizer. In data released by these two companies, the molnupiravir was found to reduce hospitalization and death at 28 days in high-risk patients by 50%, so that's pretty good. Paxlovid showed even better results, 89% reduction in hospitalization and death at 28 days. So this was like from 8.2% hospitalization and death to 0.7 at 28 days. Both are given for a 5-day course. The Paxlovid Pfizer is co-administered with ritonavir. Ritonavir is a protease inhibitor. It's actually used for the treatment of HIV, but it's given in this case as a pharmacologic booster to increase the serum concentration of Paxlovid. Again, both of these are not yet available in the US. The FDA is supposed to be meeting at the end of the month to discuss molnupiravir. They're both felt that will probably cost about $700 per course. And actually the Paxlovid, supposedly in the news yesterday, the federal government supposedly contracting to buy several tens of millions of doses of it. And the cost there that was estimated at $500 a course. Again, these data for molnupiravir and Paxlovid are not published yet. These are basically by press release, although for molnupiravir, at least they're supposedly have submitted their data for review to the FDA. And because they're not readily, we don't have the data yet, the NIH guidelines do not address these agents. But again, these are on the horizon. So these could significantly affect our treatment for HIV, because again, for now, till now, we do not have any oral medications for the outpatient treatment of COVID-19. What about hospitalized patients? Again, I turn to the NIH treatment guidelines for hospitalized adults with COVID-19. Basically, they stratify their recommendations by disease severity, and they have different recommendations for each level. The disease severity basically is determined by their oxygen needs. So the mildest cases sort of are hospitalized, but do not require supplemental oxygen. Basically, they're just being monitored. And then the next level is those that require low-level supplemental oxygen, basically oxygen by nasal cannula. And then there are separate recommendations for those that require high-flow oxygen or non-invasive ventilation, such as BiPAP. And finally, those that are intubated in the ICU, so those that require invasive mechanical ventilation. And basically, I summarize them here. For those on no oxygen, it's mainly supportive care. For those with low-level oxygen, again, by nasal cannula, the options are remdesivir and dexamethasone. For those on high-flow oxygen or non-invasive ventilation, the same options, remdesivir, dexamethasone. And for those recently hospitalized with rapidly increasing oxygen needs, tocilizumab and baricitinib. And finally, those in the ICU intubated, it's dexamethasone and tocilizumab, at least for those early in the course of ICU admission, generally within 24 hours of ICU admission. I don't have time to go into the details of all of this, but I do want to review exactly how effective are these treatments. So how effective are they? Dexamethasone, so basically is probably the least controversial of them, that has strongest data. And in the recovery trial, you here see efficacy for dexamethasone showed 17% reduction in the 28-day mortality. Overall, there was no benefit for patients who were not on oxygen. And overall, still, so that mortality came down from 25% to close to 26% to 23%. So about an absolute risk difference of 3%. But that's sort of significant, but still fairly modest in the large scheme of things. Remdesivir was even weaker. Remdesivir has not really shown any mortality benefit. So in fact, the WHO guidelines do not even recommend remdesivir. Remdesivir basically shortens time to recovery from 15 days to 10 days. And tocilizumab, for instance, in the recovery trial also showed an 11% reduction in 28-day mortality from 35% in the placebo arm to 31%. Again, a somewhat modest improvement. And again, this was mortality benefits were not seen in other studies. So the data has been very mixed. Any other recommended treatments for COVID-19? Convalescent plasma was a big one that we used a lot early in the pandemic, but now there are multiple studies that showed that there is no significant benefit. So the NIH guidelines and the IDSA, the Infectious Disease Society of America guidelines, both recommend against the use of convalescent plasma. Prophylactic anticoagulation, basically basic routine DVT prophylaxis is recommended for all hospitalized patients. Early in the pandemic, we were looking at sort of higher dose, more intense anticoagulation, but right now there is not enough data to support that, but certainly just a prophylactic anticoagulation. Hydroxychloroquine, again, early in the pandemic was sort of routinely used, but now there's sufficient data to say that it has no benefit. So both NIH and IDSA guidelines recommend against. Ivermectin has been a lot on our minds and in the news, both in the US and in the Philippines. But yeah, while there have been multiple studies, the quality of the data supporting it has really been very weak. So the NIH guidelines, for instance, say there's insufficient data to recommend for or against. The IDSA guidelines go so far to suggest against, except in the context of a clinical trial. Similarly, famotidine, vitamin C, vitamin D, zinc, there have not really been sufficient data to recommend to support the use of these agents. Bottom line, we do not have a silver bullet for the treatment of COVID-19, particularly for our sickest patients in the ICU. Basically, we have a toolbox, a toolkit of different treatments, and most of them with mild to modest efficacy. And because of that, unfortunately, we still have lots and lots of people dying from COVID every day in our ICUs, even in the wealthiest country in the world with all our resources. Every day, for instance, yesterday, 1,213 people died from COVID-19 in the US, despite all these medicines that we have for treatment of hospitalized patients. That's the equivalent of 3 jumbo jets full of people dying every day, which really is a tragedy. So bottom line, we have treatments, but none of them are really, we don't have a cure, we don't have really good treatment. So I will end with this last slide. Prevention is always better than cure, and we don't have a cure yet. So prevention is always the best defense. And this graph from the CDC just goes to show the rates of COVID-19 deaths by vaccination status in the US. The black line shows the death rates for the unvaccinated, and the blue line shows those that have been fully vaccinated. So basically, overall in the US, say as of August, unvaccinated persons had 11 times greater risk of dying from COVID-19, because if you get sick and you become hospitalized, we have treatments, but they are not as effective as we like. The effects are modest. So bottom line, vaccinate, vaccinate, vaccinate. And with that, I turn you over to Dr. Felizarta.
So good evening to all of you. Sa mga taga-Pilipinas, magandang umaga po sa inyong lahat. I'll be discussing the updates on modifying factors of COVID vaccine effectiveness. I'll be discussing more of the science rather than recommendations. I have about 15 slides, so hopefully we can finish this in less than 15 minutes. So what are the levels of protection or immunity? And usually we look at 4 things. One is immunity against protection against infections, usually including asymptomatic infections. Number 2, protection against symptomatic infections. Number 3, protection against hospitalization. And 4th, death. The antibody levels are very important in protection versus infection, but the T cells become more important for protection versus hospitalization and death. Now, these are the factors affecting protection versus SARS-CoV-2 infection and COVID-19 disease. So, of course, vaccination status is very important. Vaccine is much better than unvaccinated. Dr. Abiad already showed you that at least for protection versus infection, it's 6 times better. And for deaths, it's 11 times better. The duration of the last vaccine dose is also important. It looks like there's a waning of immunity for protection, and less than that for COVID disease, though. And we'll talk about that later. But it looks like the half-life is about worst case scenario will be 3 months. So that means if the protection is 95% initially, after 3 months, it can go down to 90%. After 6 months, it can go down to 80%. And after 1 year, it can go down to 50%. The vaccine product and boosters are also important, and we'll talk about that later. Of course, natural infection is also important in terms of symptom severity of natural infection. Of course, you don't want to have a natural infection before vaccination because of the increased risk of dying and hospitalization. Variants are important, and age and comorbidities are more important for protection against disease, and that includes hospitalization and deaths. So this is showing you the age-specific mortality patterns of SARS-CoV-2. As you can see, an 80-year-old patient will have an infection fatality rate of about 10%. 60-year-old will have a 1%, 40-year-old 0.1%, and a 20-year-old will be 0.1%. So if you're comparing a 90-year-old and a 20-year-old, that will be a 70-year gap. That would translate to a 1,000-fold difference in mortality rate. Now, this actually looks like the natural risk of dying from all causes. So essentially, SARS-CoV-2 doubles the mortality rate of all causes. And yes, the mortality rate of a 20-year-old is 1,000-fold lower than 90-year-old, but that's expected too if there's no COVID. So the most important thing to remember here is COVID essentially doubles the mortality rate, at least for 20 years and above. So even if it's 1,000-fold lower, the mortality rate for 20-year-old, if it doubles, that could not be acceptable. Now, what are the reasons for this increase in death with aging? It's because of the pool of naive T cells is diminishing with age. And it's very important. This adaptive immunity is important because, as we know, in severe COVID, you have this delay in innate response and inadequate T cell response. So there's overcompensation of the innate response later on, leading to hyperimmunity and might lead to hospitalization or deaths. Now, this one is showing you the correlates of protection against infection and severe disease. This is based on meta-analysis of all the phase 3 trials. As you can see here, the mRNA 1273 is Moderna, so they're the best, Moderna and Pfizer. Moderna is a little bit better than Pfizer. There's a twofold better in neutralization level compared to convalescent. This one is J&J and AZ, which is half of that of convalescent, and CoronaVac or Sinovac is 1/4 of convalescent. However, in this study, they showed that the correlated protection is 20% of the mean convalescent titer. That's 1/5. Okay, CoronaVac is 1/4, so that's still better. Not only that, the threshold for protection against severe disease is even lower, 3%. That's 1/30. The problem is, if you have variants and there's for example, that's a 5 to 10-fold decrease in neutralization titer, of course, the efficacy will decrease. This study by Gilbert et al. Is actually showing that the vaccine efficacy is 51% for Moderna vaccine recipients, even if the antibodies are undetectable. So even with an undetectable viral load, undetectable neutralizing antibody, the vaccine efficacy is 50%. So it means it's not just antibodies, there's something else. So in this study, they have shown that the 68% of vaccine efficacy against symptomatic infection was mediated by the neutralization titers. So it means 32%, 1/3 of the efficacy, vaccine efficacy, is probably secondary to cellular immunity. Now let's go to the variants now. This one is showing you that the Delta variant has a higher viral load compared to the other variants. So the lower the city value, the higher the viral load. And the red is Delta, orange is Alpha, and green is the ancestral or wild type. And based on this, the Delta viral load is 10 times higher than that of Alpha and 1,000 times higher than the wild type. But if the patient has a breakthrough infection, let's say the patient is vaccinated and got an infection that's called a breakthrough infection, the viral load will still be the same in the first 5 days, but there will be a dramatic drop in the viral load after 5 days. So it probably will not prevent the infection, but definitely it should decrease hospitalization or deaths. Now let's look at the vaccine effectiveness, the most updated data for vaccine effectiveness. So this one is against infection at New York State. And as you can see here, from May to August, there's a gradual decline in the vaccine effectiveness from about 92%, more than 90% to about 75%. But after July, it stabilized. And this is regardless of the age group. And this is probably because of this could be explained partly by the increase in Delta variants and partly by the waning of the immunity. This one is against hospitalization. So the previous one is against infection. This is protection against hospitalization in New York State. And as you can see here, the vaccine protection against hospitalization is stable from May to August. There's no decrease overall. But for the elderly, though, 65 years and older, there's some decrease in vaccine effectiveness. That's why the initial recommendation is to give a booster dose in patients who are 65 years and older. Now, this one is the vaccine effectiveness of Moderna versus asymptomatic infection. So this is quite busy, but most important thing to remember here is three things. One is there's a decrease in immunity with the increasing duration from the last dose from the second dose of Moderna. So there's a decreasing immunity with time. Second is there's decreasing immunity from pre-Delta to Delta. And third is the curves look similar across age groups. So it doesn't matter what the age group is. There's a decrease in immunity from pre-Delta to Delta and with increasing duration from the last dose of Moderna. This one is Pfizer. The same thing with Moderna. The only difference is Moderna is a little bit better in terms of efficacy. And we already expected this because the decreasing neutralizing antibody is twofold better with Moderna. And this could be explained probably by the dose. Moderna is 100 micrograms and Pfizer is only 30 micrograms. Johnson & Johnson is even lower, but this is an unfair comparison because essentially we're comparing 6 weeks after the first dose of Moderna and Pfizer, and we're comparing it only with 2 weeks after the first dose in J&J. We already know that the immunity keeps increasing with time, at least in the first few months. Now, this one, I only have 3 slides left. So this one is this one is showing the predicting vaccine efficacy against SARS-CoV-2 variants. And as you can see, compared to the ancestral, the alpha variant is lower. This is, of course, originally from United Kingdom. Delta, originally from India, is even lower. And of course, beta from South Africa is the worst. But the important thing to remember here is the efficacy is much better against severe infection versus symptomatic infection. Now, this one is a busy slide, but this is the study showing the predicted effect of a booster dose on neutralizing antibody response. So let me give you an example. So for severe infection, okay, this one, the x-axis is the efficacy. And the black line is the ancestral virus. This is alpha, purple is delta, and this is beta. So let's look at delta. So for delta, if you have, this one is Pfizer. If you have Pfizer, it's about 90% efficacy against severe infection. With Moderna, it's about 95%. So we already mentioned that Moderna is a little bit better than Pfizer. But with Sinovac, it's about, with the ancestral viruses, it's about 85% based on the Chile data. But with Delta, it's about 55%. But if you boost it, so if you have 3 doses of Sinovac, it goes up to 85% again. So, and remember, this is the median predictive value. So the 55%, the 95% confidence interval is quite large. So the 55% could be actually 85%, and the boosting with 85% could actually be almost 100% for Sinovac. And this is the last slide I have. It's predicted protection from SARS-CoV-2 infection and the effect of boosting at 6 months. Remember, the half-life is about 3 to 4 months. So if you have a 95% efficacy initially, it will become 90% at 3 months, 80% at 6 months, and to 50% at 12 months. So there's no, the 6 months is very arbitrary. It will not drop dramatically after 6 months. There's a gradual decrease in efficacy. However, if you boost it at 6 months, especially for severe infection, the protection can go up to almost 100%, and the waning of the immunity is even slower. Thank you. So I'll be turning this over to Dr. Santo Tomas.
Good evening. I've been asked to limit my talk to 15 minutes at the most, so let's go. You may have heard different terms for this. There's long COVID, post-acute COVID. post-acute COVID syndrome, and a bunch of other terms. And that's just a reflection of how the terminology and even the case definitions are still really evolving. For our purposes, I'm going to use the term post-COVID conditions because the NIH and the CDC currently use this definition or use this term. And what this is it's an umbrella term that describes a wide range of new, returning, or ongoing mental and health physical problems in patients who are 4 weeks or more after having COVID-19 infection. Now we know from previous experience that post-infectious sequela and health problems do occur even with other diseases we've encountered before. So like, for example, with the post-polio syndrome, rheumatic heart disease, Guillain-Barré syndrome, Reiter syndrome, and the post-treatment Lyme disease syndrome. So these are all examples of such phenomena. Now, in this study of more than 270,000 patients who were survivors of acute COVID-19, and this research was mainly done with an electronic health record review. What they found was that 1 in 3 patients had 1 or more symptoms of long COVID that were recorded or reported between 3 to 6 months after the acute infection. And in 2 of 5 of those patients who had long COVID features in the 3 to 6 month period, there were actually 2 to 5 who did not have any such symptoms in the previous 3 months. So meaning they just started after 3 months. And they also noted that long COVID symptoms were higher in more severe acute illness in those who are young adults as well as in females. So when you look at this graph, what you can see is that the most common symptoms reported actually included anxiety and depression. There's abnormal breathing, throat clearing, fatigue, headache, and cognitive symptoms. They then did a comparison for a matched cohort of patients who had influenza. And in this graph, this is a Kaplan-Meier curve, which shows the cumulative incidence over time from 90 days to 180 days of symptoms that have been described with long COVID. And you could see that the pink line there at any point during this 90 to 180 days, the reported symptoms of long COVID were much more in patients who had COVID compared to those who had influenza. In this slide, the researchers further showed that the risk of having the symptoms of the components of abnormal breathing, chest, throat pain, myalgia, anxiety and depression, abdominal symptoms, headache, fatigue, cognitive symptoms. For all of these symptoms that were experienced in people who had the flu, in this case represented by the line in the spider graph in this one referent area here, you could see that the risk for those who had COVID is almost twice, okay, represented by the red-orange line over here. So that is a significantly higher risk that we see in patients who had COVID-19 compared to those who had the flu. Now, in this other study of patients who are 1 year from surviving COVID-19, they were discharged 1 year after having COVID-19 from hospitals in Wuhan, China, you could see that up to actually 45% of those surveyed still had symptoms. And the symptoms include any of these listed here, as you could see. And the most common ones are fatigue, sweating, chest tightness, anxiety, myalgia, palpitation, cough, shortness of breath, and the list actually goes on to a second page, which I did not include here. But what you notice too is that the percentages are higher in people who had severe disease compared to those who had non-severe disease. And yet they still occur even in non-severe disease. Now, as far as mechanisms of disease, there's probably more than one, or it could be a combination of different mechanisms that may explain the development of post-COVID conditions. But this would include unmasking of pre-existing disease, sequelae of organ damage from the acute infection, autoimmunity, and dysregulation of the immune system. And some have proposed a possible latent or chronic infection, but that still needs to be proven. Whatever the mechanisms are, we know that a number of diseases or abnormalities and diagnoses have been reported in these patients. So cardiovascular diseases include myocarditis, heart failure, pericarditis, and postural orthostasis and tachycardia syndrome. In my field, I see interstitial lung disease and a reactive airway disease, which is similar to other post-viral bronchial hyperresponsiveness. And there's quite a number of neurologic entities that have been reported. So stroke, TIA, olfactory and gustatory dysfunction, sleep disturbances, cognitive and memory problems, headache, neuropathy, and dysautonomia. Of course, some people who may have had acute renal failure may continue to have chronic renal disease even after the acute phase. And then rheumatologically, there are reactive arthritis, fibromyalgia, and other connective tissue diseases that have been reported. In psychiatry, the reported problems include depression, anxiety, PTSD, and even psychosis. There have been reports of alopecia and skin rash. And of course, in hematology, there's venous thromboembolism. Some people may complain of incontinence and sexual dysfunction. And finally, some may be diagnosed to have diabetes and hypothyroidism. And again, whether that is because of the SARS-CoV-2 or may have unmasked it, sometimes that may be hard to really tell. I'm just going to go quickly through this, just so people are aware. Of course, we have this multi-system inflammatory syndrome that is seen in children. And the average time it occurs is presumed to be around like 4 weeks after an infection. Sometimes it's not clear when the infection really is. And there's, of course, a number of criteria as listed here that you have to go through to kind of make a case diagnosis for this. And it doesn't just occur in children. And although probably it is less common in adults, but a multi-system inflammatory syndrome in adults has also been described. I won't go through all of the details there, but you could go and read that later if you want. And this is just an example of a case in an adult COVID-19 associated Kawasaki-like multi-system inflammatory disease. In this adult who presented with, here you have a heliotrope rash and subconjunctivitis, mucositis right here, there's pedal edema, palmar erythema over here, and a maculopapular rash. Okay. The diagnostic approach to post-COVID conditions definitely needs a good history and exam. Okay, and there's no single test for a post-COVID condition to make that diagnosis, and we need to tailor the tests that we do according to the findings that we gather from our history and physical exam. For those who may just have mild disease or mild symptoms, especially in the first 4 to 12 weeks, then a watchful approach, meaning you may not need to do any testing if it's mild and during that first 4 to 12 weeks. Most cases can actually be handled in a primary care physician's office, but for more difficult cases, then definitely consider referring to a subspecialist. One thing that I've found very helpful in clinic is, of course, doing the pulse oximetry. It makes me triage or helps me triage patients who may be more severe and need earlier testing. The CDC also recommends doing some postural check of blood pressure and heart rhythm to see if there is significant orthostasis. And then for laboratory testing, again, depending on what you see on your history and physical exam, of course, you could get the basic, complete blood count, kidney function, liver function, check the inflammatory markers, thyroid function for those who may be complaining of fatigue, and also check for vitamin deficiencies. If the history and physical exam are suggestive, then you should check for rheumatologic conditions, okay, and serology. And for those who may have coagulation disorders, then of course you could check your D-dimer and fibrinogen. For cardiac concerns, you could check your BNP and troponin. Additional tests that could be considered include, of course, EKG, transthoracic echo, stress testing, and tilt table testing to look at POTS. In my field, I do pulmonary function test, and then depending on the physical findings or on exam, then either a chest X-ray, a CT scan, or a VQ scan. There are some things or studies that maybe you don't really want to do and may have a low yield in certain circumstances. So for example, getting a CT a chest, it has low yield if you already have a normal chest X-ray and normal oxygen saturation. A CT pulmonary angiogram to look at like pulmonary embolism also has a low yield if there is a low D-dimer and no compatible symptoms of pulmonary embolism. And then for that very common complaint of brain fog, just getting an MRI if there's no localizing sign may also be really low yield. The management of post-COVID conditions should be an interdisciplinary process, although most may be dealt with in the primary care physician's office. There are some who definitely need to be seen by subspecialists. So it's important to involve the patient as well in management. So prioritize and set goals with the patient. And as I said, refer to a subspecialist if needed. Don't forget about mental health and psychosocial interventions, and also don't forget about physical therapy and rehabilitation when appropriate. To summarize, there is a wide range of physical and mental health consequences that may be experienced by some patients who are 4 weeks or more from the acute infection with SARS-CoV-2. It can affect patients, not just those with severe disease, but also those who have mild and even those who may have been asymptomatic at the start. Now consider a focused laboratory and imaging approach as far as testing that is based on your history and physical exam findings. But remember that the lack of laboratory or imaging abnormalities does not invalidate the existence, the severity, or the importance of the patient's complaints and symptoms. Address specific symptoms for care and employ a holistic approach. Our understanding of post-COVID conditions really at this point is incomplete. So it is likely to change over time as we get more data, and hopefully that helps us and our patients as well. Thank you very much for having me.
Thank you everyone for those most informative talks. Just as a reminder, if you would like to ask a question, please use the Q&A function in the chat box. And there have already been some questions that I would like to address. I know Dr. Felizarta addressed some of them online, but just so everyone can get the benefit of the answers, I will recap. So there were a few booster questions, questions about boosters for the vaccines. Are booster doses going to be recommended soon, especially in children who have been 6 months over their last immunization? What is the effectiveness of boosters? And do you still need boosters if you've had the first series and you already also had COVID infection?
So yeah, I've already answered one of the questions. So if you already had a natural infection and then you had a vaccination. Remember in one of the slides that I've shown, if you have a natural infection and you have even one dose of Moderna as a booster, it's as good as 3 doses of Moderna. So of course the formal recommendation is at least still to give 2 doses. So that should be more than enough. So you don't really, after a primary vaccination, you don't really need a booster if you had a natural infection before the primary vaccination.
Do you think booster doses will be recommended soon among children who have been vaccinated?
Well, the FDA just approved the booster dosing for anyone 18 years and older. The problem is the best benefit ratio, the benefit risk ratio for less than 18 years old. So for example, the myocarditis rate for 16 to 17, at least for younger males, is 1 in 10,000. Now, but most of the myocarditis though is mild. You know, it's very rare to get ICU admission because of vaccine-induced immunity. And then you have to compare it with the death rate, which is really 1 in 10,000 for that age group. But the hospitalization rate is 1 in 1,000. So if you look at the benefit risk ratio, I still think there's more benefit than risk. But still, they have to lower the dose though. So for Pfizer, remember the dose for Pfizer for 5 to 11 is 10 micrograms. The adult dose is 30 micrograms. And Moderna booster is 50 micrograms, and the full dose is 100 micrograms. So if you compare to the full dose, Moderna is 1/10. So I and remember the reactogenic adverse events and side effects usually depends on the dose, and of course the efficacy too. But we don't need a lot of efficacy for younger individuals. So it's a tough call, but if you have a lower dose of Pfizer or Moderna, I think the benefit outweighs the risk.
There is a question about what the vaccine recommendation is for pregnant women. Has there been neonatal effects if the mother was infected? And Dr. Cruz, you might want to answer that too.
I apologize for my background noise. All pregnant women are expected to get the vaccine no matter what gestational age, and there has been no neonatal effects. And there's actually been some actual data to show that infants of moms that were affected by COVID actually has antibodies. So we're hoping that moms that actually got vaccinated, mainly closer to the 3rd trimester, will also provide antibodies to their neonates.
And for those of you who don't know, Dr. Cruz is one of the PMA-Wisconsin. She's our tech support, but she is a maternal high-risk pregnancy specialist at the medical college. There is a question for Dr. Santo Tomas. Do you have any data about what the longest period of post-COVID illness is?
Well, that I think we'll have to continue to follow, right? One of the studies I cited, that study from Wuhan, China, they had around almost 2,500 patients. Those patients were 1 year after having COVID. So if it's 1 year, so what, they had their epidemic start in December, January, and now it's almost since January, it's 10 months, right? Now the thing is, we don't have it's really an ongoing thing. So maybe they could have a follow-up study by next January, and we could see whether some patients, some of those almost 50% of patients who are complaining of symptoms, maybe we could see if they still have symptoms. But as far as larger studies, that's, I think, a good study to cite. Now, you may know some people anecdotally who may still be complaining, but as far as a study, I think that's a good study to show that at least 1 year, you still have people who have significant symptoms.
There are a couple of questions. Thank you for that. There are a couple of questions about mixing vaccines, about having like 2 doses of Sinovac and then 2 doses of Moderna, or having a different type of vaccine for your boost. Can one of the panelists comment on this? Maybe Dr. Felizarta.
Well, the recommendation for boosting, you can use any vaccine for a booster. Although there's a study that's shown that after J&J, the neutralization is much higher after Moderna and Pfizer. Moderna was a little bit higher than Pfizer. Then if you use J&J as a second dose, it's lower than the mRNAs. So at least for boosting, mRNA is still, at least based on neutralization, is better than vector vaccines are like J&J and AZ. Although if for mix and match though, this is not boosting, just mix and match. There's some data that if you use mRNA and you use a vector vaccine as a second dose, it will be the same as two mRNAs, but in terms of cellular immunity, it might be higher with mRNA and then a vector vaccine, but we have to confirm that.
Dr. Abiad, discuss for you, what is the mechanism of action of the Paxlovid and molnupiravir? And what are those the things that are, what are the mechanisms of action of the drugs in the pipeline for COVID?
So those those two, they're basically direct antivirals. So they do interfere with the cellular sort of basically with the transcription of the in the production of the viral protein. So they're similar to sort of the antivirals we use, for instance, for HIV. So they're as opposed to say currently our most commonly used ones like dexamethasone, tocilizumab, which are more immunomodulators. Remdesivir is directly antiviral, but again, its effect is not that great. Again, so these two are directly antiviral by interfering with the cellular production of the viral proteins. But hopefully, again, if it bears out, hopefully we'll see good results.
Can I add to that? So the Merck molnupiravir is a protease inhibitor, and the Pfizer is a protease inhibitor, but the Merck molnupiravir increases actually the mutation rates. So it's almost like a suicide.
Yeah.
It pushes it to suicide.
I guess that's one question I was thinking maybe we should address it here. I'll have you address it because some people have like raised the question of, because of its mutagenicity, what are the implications as far as the drug, as far as human mutagenicity? That's been a question, of course, with the mRNA vaccines. And so I would expect that would be something that comes up with people who are wary of this new drugs. Any thoughts on that as far as mutagenicity, the molnupiravir in particular? Sorry.
Franco, you want to address that? I have no. Again.
We don't have. The problem is we don't have long data on resistance after molnupiravir, but most likely this will be like the HIV treatment paradigm. We're gonna have, give it a year. We'll combine these two. We'll probably combine these two to decrease resistance. So, but the other, molnupiravir has this interesting, this mechanism of action.
Yeah, I know. It is interesting.
So in terms of, the long-term safety, again, obviously, long-term, you're going to need time, but time will tell. But I think theoretically, hopefully, it's restricted to the viral, just production of the viral proteins, and will not affect our human normal cellular processes. We'll see.
But the efficacy is like we already mentioned 90%, almost 89, almost 90% for the Pfizer pill, but
for the
much lower for the mono, which is 50%. So, but most likely, give it time, we'll probably combine. We're going to have a combination against this virus.
Thank you.
The one thing also for these both the two medications, although again they're very expensive here. Again, both companies have entered into like licensing deals with generic production making companies in 100 low-income countries, so that they'll be developed there and be able to be available there, basically just above production cost, much cheaper than here. So actually, that's a good development for low-income countries.
Good.
Do any of you foresee that COVID vaccination will be an ongoing vaccine that may be required every year, like the flu vaccine? Anyone?
So there's
Oh, don't all rush to answer it.
Go ahead, Franco.
So there's two things there. So in terms of mutation rate, we know that the mutation rate for SARS-CoV-2 is lower. At least initially we thought it was like 5 times lower, but now it's like 2 times lower than influenza. So if based on the mutation rate, it should be the booster frequency should be much lower. The problem is the waning of the immunity. So we don't know. So but if you look at the neutralization though with after boosting, it looks like boosting the half-life will be probably longer. So usually it's 3 to 4 months, but if the half-life should be the same, but it starts with a higher neutralization. So we recommend the boosting after 6 months. So hopefully after booster, hopefully it would be at least a year, and after that at least should be longer. So I'm just speculating here that we probably would not need a yearly booster with the COVID-19 disease.
Again, the thought is that although right now we're calling them boosters, I guess the thought is maybe this really we should be thinking of them as like a three-dose primary immunization, sort of like for hepatitis B, for instance. It's now we know it's sort of 3 doses. Of course, we're developing 2-shot ones, but yeah, so maybe clearly like J&J was called initially a 1 dose. It's clearly not. And so for the mRNA, which we said it's a 2 dose, maybe actually it is a 3 dose. And the third, which we're calling right now a booster, you can consider it the 3rd dose of your primary series.
And ultimately, we'll find out next year.
Yes.
And remember, for immunocompromised patients, we don't even call it a booster. You probably need like 4 doses of, or maybe higher.
Right.
For example, for AIDS patients with their CD4 count less than 200, we don't even immunize them. We wait for the CD4 count to be more than 200 because it's not so effective when the CD4 count less than 200. And like for Hep B immunization, we double the dose. If it doesn't work, we double the dose of the second vaccination series.
So there's some questions about boosters and protective immunity after an infection. It looks like the FDA has authorized booster doses for all adults, regardless of previous infection. Any comments or clarification about this?
Let's say you have a natural infection, and then you already had a primary vaccination series. The question is, do they need a booster?
Yes, I think.
Well,
I think you addressed it in the talk, but so, maybe.
The data already showed that even with 1 dose after natural immunity, it's almost equivalent to 3 doses of Moderna. So I'm pretty sure 2 doses should be more than enough. The question is, would they need a booster 1 year after, 2 years after? We don't know. I'm speculating they probably would not need a booster for a long time if they had natural immunity.
But would you recommend for males who are under age 40, would you recommend the J&J vaccine over the mRNA vaccine, given the myocarditis risk? But I believe you already addressed the risks of myocarditis in patients get COVID vaccine versus if you actually get COVID, and the risk benefit is still. But are there vaccine choices that you recommend for such, or similarly for women who are younger to avoid the sinus venous thrombosis risk?
Yeah, I mentioned that the risk is for 60 to 17, the risk of myocarditis 1 in 10,000. So, but most of them are mild. Now, the risk of cerebral venous thrombosis in younger women is like 2 to 3 in a million. The problem is it can be fatal. So so for younger women, I would go for mRNA over J&J. Now, for younger males, it's a tough call, but there's some data from Canada showing that there's more myocarditis risk with Moderna versus Pfizer, which can be explained by the doses, 100 micrograms versus 35 micrograms. So probably, if if I'm pushed to recommend a choice, then Pfizer over Moderna for younger males. Now it's a tough call between J&J and Pfizer for younger males because yes, the myocarditis risk is much higher, but the fatality is much lower compared to cerebral venous thrombosis.
I think we have time for one more question. If someone got the full 2-dose course of Sinovac, would you recommend mRNA vaccine? So I guess deliberately switching up your booster doses is the question.
Well, it's not approved here in the United States, Sinovac, so I don't have to answer that.
But for the
So I
Philippines.
guess this is a question from
I thought I
abroad.
could. So, well, I've shown you the meta-analysis and the predictive efficacy for Sinovac, and for the ancestral vaccine, and this is actually based on the Chile data. It's about 80% against severe disease, hospitalization, or deaths against the ancestral vaccine. But that data, because most of at the time, it's pre-gamma, but now Chile had gamma and then delta this time, and they already had their winter season. And if you look at their epidemic curves, it looks okay. So yes, so with the delta, it shows it decreases to a 55%. That's mean, but the 95% confidence interval is pretty large. So I mentioned it could be actually more of 85%. But definitely after 6 months, there'll be if there's waning of immunity with the mRNA, I'm pretty sure there will be waning immunity with the Sinovac. So definitely I would recommend a booster dose. In that data, though, it shows that if you boost with another Sinovac, the protection against severe disease goes up to about 85% with the ancestral, but might be lower for the delta. So, if I have a choice, I would choose an mRNA over Sinovac as a booster for patients on primary vaccination with Sinovac. Yeah. And then, it's probably going to be Pfizer because, Moderna, I'm not sure if it's already approved there as a booster. But remember, the Moderna booster is 50 micrograms. It's half the full dose. And so, the problem is some people might try to get a second vaccination series. So that's 100 micrograms after Sinovac. You might get more side effects with that strategy of revaccination.
Thank you again to all our speakers. There's several comments in the chat box about how excellent and informative the talks were, and we greatly appreciate your time and effort. Thank you, Dr. Felizarta, Dr. Abiad, and Dr. Santo Tomas, and Dr. Cruz for tech support. We, just as a reminder, we are recording this, and this will be available. We will probably email it or get it to you the same way that we got you the poster for the talk. If any of your questions were not addressed, we will try to address them offline.
For more information on the Philippine Medical Association of Wisconsin, find us on Facebook and Instagram.